couple of announcements I'd like to make. One is that we have a serious illness conversation guide opportunity that's coming up. This is our partnership that Comagene Health has with the University of Utah College of Nursing and Huntsman Cancer Institute. So we will be hosting provider trainings based on the serious illness conversation guide. And based on the information that we've seen so far, it really resonates that we need to be having providers trained to have these conversations. So we have flyers out there, and the training will be open to nurses, providers, anybody working in home health agencies, nursing homes, and assisted living. So feel free to take a flyer home. It's on the table that has the community resources out there. And I am so happy to have Dr. Tim Farrell and Professor Lee Ellington with us over here. And they're going to be talking to us about a slightly different perspective. We're going to be learning about how do we provide care for the caregivers and looking at advanced care planning from the perspectives of the socially isolated. So Dr. Tim Farrell is an associate professor of medicine and adjunct associate professor of family medicine at the University of Utah and is a physician investigator at the VA Salt Lake City Geriatric Research, Education, and Clinical Center. He also serves as the director of the University of Utah Health Interprofessional Education Program, and in this role collaborates with the National Center for Complex Health and Social Needs to lead one of 4 U.S. hotspotting hubs. Dr. Farrell received his MD from the University of Massachusetts, followed by a family medicine residency and geriatric medicine fellowship training at Brown University. Thank you, Dr. Tim. And Professor Lee Ellington, I'm going to do the introductions for both, so then I can leave y'all to go. So Lee Ellington is a professor and holds a Robert S. and Beth M. Carter Endowed Chair in the College of Nursing, University of Utah. She is also a Huntsman Cancer Institute investigator and a licensed clinical psychologist. Her interdisciplinary program of research is focused on family, patient, provider communication, and for the last decade, her primary research interest has been in meeting the health and well-being needs of hospice family caregivers of advanced cancer patients through communication processes. Additionally, she is actively engaged in research, mentoring, and co-directs a program for interdisciplinary training for cancer caregiving and end-of-life care research. Thank you so much for being here. So what we will do is we'll have a presentation by Dr. Tim Farrell and a presentation by Professor Lee Ellington, and then we'll open up for Q&A.
Well, good morning, everybody. Thank you for the invitation. Hopefully we're good with the audio visual in the back. I wanted just to frame my remarks by talking about an important question, which is what matters most. And Representative Chavez got me thinking about this when she talked about needs and wants. And so the question I've started asking to patients in clinic is what matters most to you? I'll come back to that in a little bit, but that's something that really is pertinent to this population of the unbefriended older adults and adult orphans. So I have no conflicts of interest to disclose. I want to start with a lonely question. What happens when a vulnerable older adult has no family or friends who can provide caregiving? A lot of our discussion so far has appropriately assumed that there is someone who can provide that caregiving and insight and help in terms of having the discussion, the serious discussion, especially near the end of life. But we're going to talk about what happens when the caregivers are not present, or maybe they're present but not willing or able to participate in these discussions. And so as you can see on this graph, there's an increasing literature on loneliness as a public health crisis. So you'll see that horizontal bar at the very top talks about or shows loneliness. I'm not sure if we have the pointer here, but loneliness, about 40% of adults in the United States, at least by CDC and US Census Bureau data, qualify as lonely. And that's more than the percentage of or prevalence of older adults with obesity, inactivity, and smoking. So this is a really prevalent issue. You can see that also about 25% of Americans live alone. So we're just starting off with a large number of folks who are lonely and or living alone. So what's the impact of loneliness and social isolation? So loneliness is a more powerful predictor of adverse health outcomes than obesity, sedentary lifestyle, and even air pollution, which are three items that are, especially air pollution one, that are pertinent here, especially in the Salt Lake Valley. And an oft-quoted but true stat is that the adverse health impact of social isolation is about the same as smoking 15 cigarettes per day. So you think about the impact of smoking, and this is even more pronounced. It's not exactly clear why this is the case, that people who are lonely and socially isolated don't quite do as well overall on average, but it's thought that being isolated and lonely kind of activates that sort of primitive fight or flight mechanism, and that activates kind of a cascade of hormones that have an adverse effect on body systems. So I want to tell you about a patient of mine named RG who kind of got me thinking about this area. So RG is 67. He is chronologically young, but I think functionally older. Type 2 diabetes, hypertension, visual impairment, and cognitive impairment, and has inconsistent medication compliance leading to uncontrolled blood pressure and hemoglobin A1C. And I apologize, I was discussing this with a more medically inclined audience, so just to translate, the BP is blood pressure, the A1C is a measure of the 3-month average of your blood sugar values, if you're not familiar with those acronyms. And this gentleman was accompanied to some visits by an aide from Volunteers of America. So his decisional capacity was in question and difficult to assess. There's another acronym. He had traumatic brain injury and limited health literacy. No known family or friends, no advanced healthcare directive. The aide from Volunteers of America was extremely helpful, but she was not his guardian, and so I couldn't really look to her to help with this, with making his healthcare decisions. And so I kind of punted and called the hospital social worker and said, what can I do for this patient? And they said, well, not a whole heck of a lot until a crisis occurs, which really wasn't that satisfying to me. This gentleman only has a vague idea of what medications he takes and why he takes them. I will often call the pharmacy for patients like this and try to see, okay, if there's a discrepancy between medications he's taking, what he says he takes, can you help me resolve it? Usually what the pharmacist said he was doing, what he was doing were almost exactly opposite. And not infrequently I get a call from Trax saying, we found a bottle of medications with your name on it, what should we do? So this was actually more the norm than the exception. Most visits would kind of go this way, and it kind of became a little bit of a pattern and quite frustrating to try to take care of him. So RG exemplifies someone who is in this unbefriended older adult category. I'm not sure if anybody here has heard this term before, unbefriended. Anybody hear this term? Not too many. It's also known as unrepresented. There are some problems with this terminology that I'll get into in a moment. There's also another population of patients who are at risk of becoming like RG, who are known as adult orphans, or I think perhaps a better term, adults without advocates. So let's talk a little bit about a definition. What is an unbefriended patient? Each of these 3 criteria must be met. The patient must lack decisional capacity regarding the medical treatment under consideration. They lack all the things we were talking about that patients should have. They lack an advanced health care directive. They also lack the capacity to execute an advanced health care directive. And finally, they lack family, friends, or a legally authorized surrogate to assist them in the medical decision-making process. So you have to have all 3 of those to be unbefriended. It also doesn't mean, one reason this term is so difficult, it's hard to capture the definition in one word because it's so nuanced, but unbefriended patients can actually have friends. They're just not necessarily those who are willing or available to help them make their healthcare decisions. Now, adult orphan, again, I don't like the term, but it's out there in the literature. They have to have 3 criteria. The first one is where there's a distinction between the orphans and the unbefriended. These folks actually retain their capacity to make informed decisions about their health care. But similar to the unbefriended, they do not have an advanced health care directive, and they lack a surrogate. So let's go back to the unbefriended. How prevalent are these folks in healthcare? It's about 16% of patients in the intensive care unit, which is a pretty high number. This is something that the ICU docs are seeing. There's actually the ATS, American Thoracic Society, which is sort of the professional organization for the critical care physicians, is putting out a position statement on this. It's about a 4% prevalence in long-term care, and we simply don't know the prevalence in primary care. Well, what I can say is that if you look at the demographics, the baby boomers are at really high risk of becoming unbefriended because among them, baby boomers, about 10 million live alone and 20% lack any family or are childless. So they are at extremely high risk of becoming unbefriended. So to kind of better get at this topic and understand what was going on from the clinician's perspective, I participated in developing a survey of members of the Professional Society for those taking care of older adults of the American Geriatric Society. And we surveyed about 123 members about their experiences with these folks and also about their experiences with the adult orphans. And we were fortunate to have a pretty good representation of folks practicing in the outpatient world, which was important because the outpatient setting is where the least is known about this group. We also got their qualitative responses to better understand what they were seeing in practice. We did have a low response rate, competing with lots of other surveys, and there may have been response bias. In other words, the people who responded to the survey may have been most likely to be affected by this issue. So just take that into consideration when we go over these results. So one of the surprises in this survey is we had many more folks who were encountering unbefriended patients frequently than I had really thought. I had come into this thinking that the ICU docs and the hospital providers would be seeing these folks, but really the outpatient physicians were seeing these patients quite a bit. So actually the least frequent scenario was to see these folks annually or less. Most folks providers were seeing these patients at least quarterly and often monthly or weekly. So at least among those who responded to the survey, who again could have been more inclined to be dealing with this group as a limitation, they were seeing these patients quite frequently. And so we asked the clinicians, well, what are your concerns about unbefriended patients? And on the bottom, the x-axis there, you can see that you've got 0 to 100. So about 80% of providers were concerned that these patients were at risk for a prolonged hospital stay. And I was sharing with someone a few minutes ago, a patient I had in residency who was from another country and did not have Medicare or Medicaid and was in our hospital for the better part of a year. And these are the kind of patients we're talking about. Aside from the most important thing to me, which is their care, the hospital administrators are going to care a lot about eating the cost for someone staying in the hospital for weeks and months, even years. These patients also can be delayed in their transition to appropriate end-of-life care, like palliative care and hospice care, because it's not clear how decisions can be made for them. There's concerns about their quality of life, about their ability to control pain, delays in appropriate treatment. So you've got a flip side. You've got delays in appropriate end-of-life care and delays in appropriate curative treatment. And then loss of rehab potential, because every day they sit in the hospital, they are becoming more and more deconditioned, losing muscle strength. And so by the time they get out, they're not able to rehab as successfully. In addition, we looked at preferred terminology. There is an issue with the term unbefriended and the term adult orphan. So we presented the respondents with a number of alternatives. And for unbefriended, what came out on top was incapacitated adult without advocate, probably a more precise term. And unrepresented was also high on the list. For adult orphan, the top two are isolated, vulnerable adult and adult without advocates. We even presented some Latin terms, none of which made the top 5. But you can see there's still some controversy as to the most appropriate term for both of these groups. So because of the challenges in caring for this population, a position statement came out from the American Geriatric Society on this group, and I want to go through some of the recommendations from this position statement. So we wanted to update an older position statement on unbefriended to really be more actionable and provide something that policymakers, and I'm glad there are some in this audience here, and clinicians can actually use. And most importantly, to advocate for what I would consider one of our most vulnerable groups in our society. So we developed this position statement with a literature review and draft from our ethics committee and got feedback from 3 other committees that were dealing with similar issues and final approval by our executive committee. And I'm going to go through a series of policy and clinical recommendations that came out of this. And some of these have echoes from what our discussion was this morning. So the first policy recommendation is to create legal standards regarding the unbefriended to be considered for adoption by all states. So we heard from the last panel about the state-to-state difficulties when you're trying to transport a pulse across state lines. Same thing with the unbefriended. So significant variability exists in legal approaches to the unbefriended, creating confusion, treatment delays, and potential prolongation of burdensome treatments. So it's an aspirational goal, maybe like the e-pulse, but we hope this will happen, that there will be more consistency in legal standards. The second policy recommendation was to proactively prevent the older adult orphans from becoming unbefriended. So we have a real opportunity here. For those of you who care for older adults, it's a little bit like delirium. You can really effectively prevent delirium. Once you get delirium, it's really hard to manage. So you can effectively prevent people from becoming unbefriended. Once you're unbefriended, it's just difficult to deal with the consequences. So in my view, older adult orphans especially are one crisis away from becoming unbefriended. So I think of my patients who are coming into the clinic who have all their faculties, but they're widowed, the kids live out of state or unavailable, and all of a sudden a medical crisis ensues. There's no one to turn to, no advance directive. Perhaps they're estranged and the family doesn't want to get involved. That's what we're talking about here. The third policy recommendation was to develop approaches to protect and promote procedural fairness for this population. And the rationale here, I know Troy has much more experience in this guardianship area, is that identifying guardians can be very time-consuming and expensive and slow. Some states, I'm not sure if Utah is one of these, but some states prohibit guardians from authorizing DNR orders. So you get a situation where you have a guardian, but they still can't really address the most important question about DNR. Now moving to some clinical recommendations, and although it's couched in clinical terms, I think those of you who are working as social workers or chaplains, others, may find these to be relevant. So consider non-traditional surrogate makers for unbefriended older adults. It should not be assumed that absence of next of kin means the patient lacks a surrogate decision maker. So if you look at this, if you look at the Utah priority order of surrogate decision making, at the bottom, I think it's number 9 or 10, they list somebody who's exhibited special care and concern and is also reasonably available to the patient. So a good example of this might be an unbefriended older adult who lives in a nursing home, no family, Medicaid is paying for their stay, and an important decision comes up. Who will you turn to in the absence of a pulse form or advance directive? It may be someone at the nursing home who cares for them and knows them well, like the director of nursing. Now, that person may be ethically conflicted because they also have an incentive to have that bed utilized from a financial standpoint, but just suffice to say that looking more broadly at people who might be reasonably available and know something about these patients' preferences, goals, and values is really important. The second recommendation is to be systematic with how you assess medical decision-making capacity. That really falls on the physicians and advanced practice providers to do this. I won't go into the ins and outs of this, other than to say that if you do this in a way that's unstructured, kind of on the fly, you can often incorrectly assume somebody has capacity or incorrectly assume someone lacks capacity, and both of those are problematic. The really important point here is that even if you have dementia, you may still retain the capacity to make some or all decisions. So someone earlier made the point about a demented patient who still had some insight. I can't remember exactly what the comment was there, but if you have dementia, you may still be able to identify who's going to make decisions for you. And even if you can't make a really complicated decision, like whether or not to go to surgery, their preferences, goals, and values should still be elicited and should still inform that decision. That's something new in the decision-making capacity literature called supported decision-making. So we should be doing supported decision-making, kind of strengths-based, rather than saying these patients have a lot of deficits. Say, what are their strengths? What can they contribute to the discussion? The third recommendation is that those with long-term incapacity should have access to a longitudinal surrogate familiar with their medical conditions and specific circumstances. So you get into situations sometimes where you have to assign a guardian. You might have a guardianship agency, and they do their absolute best, but they're limited, at least initially, by not knowing the patient very well. So ideally, you would have set up a guardian for a patient before a crisis happens, so they at least get to know something about the patient's preferences, goals, and values when an important decision comes up. The next one is, if you're in the situation where you are applying the best interest standard, that's sort of like the last resort when you've got no capacity, no advance directive, there's not time to get a guardian. The physicians and the hospital, maybe an ethics committee, get together and try to just kind of do what's right and figure out what do they think is in the patient's best interest, sort of as an ethical principle. And so when it goes to the ethics committee, the recommendation is they should broadly synthesize all the available evidence, not just what's in the medical chart, but they should go to friends, care providers, clergy, any prior statements or wishes the patient made to increase the likelihood that the decision that's going to be made for the patient, in this case, is most likely to align with their preferences, goals, and values. So those are the key recommendations from the position statement, but there are still barriers, even among very well-intentioned healthcare professionals, to having these discussions. And one is, as I mentioned, that patients may be unable to participate or improperly assumed to be unable to participate in these conversations at the end of life. So that's why the capacity assessment is so important to get right. There's that lengthy process of identifying a guardian that can prolong burdensome or potentially inappropriate treatments and delay palliative care. So there's a literature on patients being referred too late to hospice, and these patients are at risk of that. They may never get to hospice when they need it, or it may be only a couple days before they can really fully benefit from hospice, and that's a problem here with these unbefriended folks. And lastly, it's extremely difficult to remove a guardian if assigned when somebody's temporarily incapacitated. So if a guardian is assigned when somebody's hospitalized and someone has delirium and they lack capacity, that patient is not going to be able to remove a guardian. Troy can correct me if I'm wrong, but my understanding is with Utah statute is that if a patient disagrees with the assignment of a lack of capacity determination, then that has to be respected. So this gets very, very tricky. So I want to talk about some promising approaches to unbefriended patients to kind of prevent them from becoming unbefriended, and if they become unbefriended, how do we help this group? So we want to identify the adult orphans proactively to prevent them from becoming unbefriended. We want to be systematic in how we conduct capacity assessments. We want to engage non-traditional surrogates to the extent permitted by state law. And then we'd like to enroll or gain access to advocacy programs such as WINGS, which some of you may have heard of in Utah and a couple other states that advocate for these patients. So someone mentioned prepare for your care at a previous talk, and this is a really important advance, I think, in this area. So those of you who take care of patients or work with patients in any way can actually use this afternoon when you see a patient. And those of you who are having discussions with your own family members, I would strongly recommend that you consider going on the Prepare for Your Care website and using this to help guide the discussion. So this was developed out of University of California, San Francisco by Rebecca Sidori and colleagues. And there are 5 different steps in this, but I've highlighted this one, decide what matters most. Okay, so really this is about deciding what matters most to patients in terms of their wishes. So when you go to fill out the advanced care documents, you've had that conversation that the last panel said was so important to have. So to show how powerful this is, the group at UCSF did a study of about 400 veterans, and the baseline rate of advanced care planning, that's the 1%, is abysmal. It's not surprising, but you've got a bunch of mostly male guys are probably reticent to have this conversation, never had the discussion before. So it's not at all surprising to me. 1% even seems a little optimistic that they had an advanced care planning discussion. When the group used a simplified, easy-to-read advanced directive document, that was from the state of California, that rate of advanced care planning documentation went up to about 25%, which is a really impressive increase from 1%. It may not seem like a lot, but that's a huge delta differential. And then when they added prepare, that got to 35%. So among a group of older veterans, we got to 35%. I would venture to say in the community, we could probably get this number closer to 50%. So it's a very strongly evidence-based intervention. So I wanted to close my remarks by just telling the rest of the story of RG. So I got sort of a distressing phone call. He was wandering in the street at about 4 in the morning. He had gone to the ER. I think he fell, was discharged, not hospitalized, but he was discharged with nowhere to go and no ride home, and almost got hit by a car. And so that's the crisis that was needed. So in a weird way, it was sort of helpful that he was almost hit by a car, because that led to his placement in a more stable residential situation. I don't know exactly what happened because he was lost to follow-up for me, but presumably a guardian ad litem or somebody, an emergency guardian was assigned, and then his care was assumed by the doc over there. So I never saw him again, but this was the patient that got me interested in this topic and really motivated me to kind of learn more about this topic. And lastly, I wanted to just comment on age-friendly health systems. How many of you have heard of that? I see a couple hands. So I think this patient is a case study for age-friendly health systems. Let me explain this. The John A. Hartford Foundation and the IHI, or Institute of Healthcare Improvement, have launched this initiative that involves a lot of the major academic health centers around the country. Their goal is, I think, to get 20% of health centers like University of Utah to be age-friendly health systems by 2020. I'm glad to say University of Utah is a participating kind of charter member of this group. And the idea is that you see these 4 M's of geriatrics up here. You've got what matters to patients at the top. You've got medications in the green. You've got mentation or kind of cognition at the bottom in blue, and mobility at the left in kind of that orangey color. And so this is the 4 M's framework. It's a new vocabulary to talk about geriatrics. I've been focusing on the what matters piece, and that really is the place to start. So I would encourage you, if you are part of a different healthcare system, to strongly consider becoming part of this age-friendly movement, because it's something that's going to really advance care for older patients, especially for patients like RG. I would argue that our health system is only as good as the care we provide for our most vulnerable patients like RG, those who have no caregivers. Just to summarize, so then our unbefriended patients are among the most vulnerable groups in our society. We encounter them more frequently than we might think. At least I believe that's the case based on the survey. There are some key policy and clinical recommendations that apply to this group. And the really important thing is to be proactive. We have an opportunity to prevent people from becoming unbefriended by doing all the things that last panel talked about, but probably a little more aggressively. These patients, especially the adult orphans, can be a little hard to spot because you might not think that they're a crisis away from becoming unbefriended, but they truly are. So you have to take the next step, ask about social isolation, what's their support network, and if they are isolated and lonely, don't just think about depression. Think also, could they become risk of becoming unbefriended? I want to acknowledge just some folks in a groups that have helped with this work. The VA hospitals in Bedford, Mass, Houston, and Salt Lake. A group called the Guardian Community Trust for supporting some of this work. Several colleagues, Jenny Moy in Boston and Casey Catlin in Boston, Eric Wadera, Anna Chodos in UCSF, Anand Naik at Baylor, and Mary Jordan Samuel from the American Geriatric Society, who all helped with that survey we went through. And happy to entertain questions. I think we'll leave them towards the end of Dr. Ellington's presentation. Thanks.